Hello everyone and welcome again to another episode of Your Health, Your Choice. My name is Dr. Roopnarine and it's a pleasure to have you tonight. With me in studio tonight is Dr. Roshni Bissoondat. She's graced us yet again, and tonight we'll be discussing further topics in women's health. More specifically, we'll be discussing pregnancy. So, as usual, the numbers will come up at the bottom of your screen, and we will do our very best to attend to your questions in the final segment of the program. So, let me say hello to Roshni and welcome back.
Hi, Robin. Good night.
Hi, Roshni. How are you going?
Good. And welcome to all the viewers.
Thank you very much. Thank you. So, tonight, Roshni, over the weekend, we met up again, and I kind of put out a fairly significant challenge to yourself, and I'm hoping that we pull off this challenge. The challenge that I had put to you was to try and put forward 9 months of obstetrics in 1 hour, essentially. So, Roshni, tonight we're going to take the viewers at home from conception to delivery. And the key part of the discussion tonight is that we would like to have the key milestone visits, what happens at those visits, the key messages that you send to your patients at those visits, and also what medical checks are done at those visits. So if you could just take us from the start, a couple comes into you at your clinic and they say, "Hi, Roshni, how are you going? We would like to have a baby. What advice would you have for us?" So if you could just take us from the beginning. Okay,
great. So the pregnancy doesn't start at when the baby is conceived, but it starts before baby is conceived. And this is called preconceptual counseling. And this is very important, especially for women who have medical issues. So first of all, medical issues such as polycystic ovarian syndrome, medical issues such as diabetes and hypertension. Now, these are the most common ones, and you'd like to know about these because you have to optimize your condition before you get pregnant. So for diabetes, you want to control your sugars because when you get pregnant, this affects a baby. Also, in terms of thyroid issues, again, your thyroid hormones are needed for every single cell and metabolism in your body. So a very low thyroid hormone is not good for a conception. Hypertension, certain medications are not safe in pregnancy. So again, you want to talk about these things with the couple so that you may need to switch medications for pregnancy and before pregnancy. Also very important would be timing of pregnancy to get pregnant, because a lot of couples feel every time you have intercourse, you can get pregnant. But that's not the case, because there's really a 3-day window in any 1 month to get pregnant. Because on average, the eggs survive 24 hours, and the majority of sperm survive 24 hours. So conception generally would occur a day before the egg comes out, the day the egg comes out, or a day after the egg comes out. So that's the 3-day window we talk about. However, as we all know, some sperm survive longer than that. But on average, 3 days. So this is what you call the preconceptual counseling. So you talk about when to have intercourse, because that you know when the egg is coming out. Women who have, what's important is polycystic ovarian syndrome. These are women who skip periods, and that's a specific condition. What a lot of couples don't realize is that there's an increased risk of miscarriages if you conceive when you have the polycystic syndrome. So we would want to would like to treat this before you get pregnant. And if
polycystic ovaries.
Not ovaries, polycystic syndrome. And there's a difference between the two.
Can you go ahead and explain the difference?
So polycystic ovaries
just taking you a little bit away from your point, but as we go along, I mean, it's important that people hear explanations of different syndromes as we go along. So what's the difference between polycystic ovarian syndrome and polycystic ovaries?
So polycystic ovaries just means you have many tiny little cysts on your ovaries, which would be 10 or more. And 20% of all women worldwide have that. But only 10% of them develop the syndrome. And the syndrome is the problem where you have irregular periods. And you also have excess testosterone. And the manifestation of that would be things like acne, excess hair growth, oily facial skin, loss of hair in your head. So clumping those together will cause a problem. So the syndrome is what causes the problem, not just the ovaries. And that, if you have the syndrome, that can put you at risk of miscarriages in the first trimester. So that's why it's important to know whether you have this before you get pregnant, because you don't want to get pregnant, end up in miscarriage, and now want to know, well, why did I miscarry?
Right.
So
and it's important.
It's important. So this is important for pre-conceptual counseling.
So in the first visit, you find out about things like chronic diseases like diabetes, hypertension. You find out what medications you're on. You might have to change your medications. It's very important during pregnancy to make sure that the person's on safe medications. What other investigations other than would you conduct at that point in time on the patient, or is there no investigations necessary?
It's not any routine investigation. It really is tailored to the couple. Finding out about whether if you have a medical condition, make sure that you're optimized. And if I pick up on something, that we try to treat it before you get pregnant.
So the take-home point for the patient at that point in time after the first visit is
when you do get pregnant. After that is actual pregnancy.
When do you start your antenatal vitamins and supplements? When would that start?
So women are supposed to be on folic acid only. That's been proven. The only thing to help with in the first trimester. And that's to prevent a condition called spina bifida.
So it's very important that women go on the folic acid before they get pregnant.
Before they get pregnant. So at least 12 weeks before conception. And most women get folic acid in the foods they eat. But if you have a low amount, then that predisposes you to spina bifida. So take your folic acid, before pregnancy.
And I think that's something very important to put out there for people to know, because in my experience, people a lot of time women become pregnant, and then we're looking to put them on supplementation.
Correct.
And I think it's helpful. We could do better by guiding patients as GPs as well when we meet them in the office. And we know them very well to go on supplementation. So after that initial visit, our patients go home, she's pregnant. When do they come back to see you?
So my advice would be anything between 5.5 to 8 weeks. And it's important. You might think this is very early. But first of all, you can actually see what's called the pregnancy sac at 5 weeks, which means
they're coming back to you to do an ultrasound.
Correct. And you see this when we say 5 weeks. This is 5 weeks from the first day of your last period, or essentially 1 week after your missed period. So you can actually see a pregnancy sac at 5 weeks. Then you can see what is called the yolk sac at 5 weeks and 2 days. And what a lot of people don't know, you actually see the baby at 5 weeks and 4 days. So this is 11 days past your period. You can see a baby and the heartbeat. It's important to do an ultrasound early because we're doing this for a few reasons. First of all, you're making sure it's in the right place. Because I don't know, you obviously know about ectopic pregnancies.
I don't know if Josh could put up those, maybe a good time for put up those slides. If you can, Josh, please, when you get a chance, you continue on.
So the reason for doing an early ultrasound, one, you're making sure the pregnancy is in the right location. Because you can have an ectopic pregnancy where the pregnancy is in your tube, it's inside your tummy, it could be in your ovary, but the most common one is in your tube.
How common is it? Sorry to interrupt, but I will be interrupting as we go along. How common, do you have any statistics? Like, is it a common thing that you see in pregnancies? Is it not common? I mean, not holding you.
So it's about 5% chances of having an ectopic pregnancy.
So the slides are up there, Roshni.
So this is the first ultrasound that you generally would see. So the big black circle, that's what you call the pregnancy sac. So that's the first thing that you see at 5 weeks. Then the little white circle inside of that is the yolk sac. And that is what feeds the baby. So you'd always then see the baby next to it. So that little white stripe under that circle is the actual baby. And it's attached because the yolk sac feeds that baby. So that's what you see early in pregnancy. Just a little,
Very good. So then the next visit would be at, I suppose, at 12 weeks?
Yes.
So we have that slide up as well.
But the other reasons for doing the ultrasound is not only for the ectopic pregnancy, you're making sure that it's one baby, not more than one. That's very important. You're making sure that the growth of the baby corresponds to the period. Because a lot of women will say they swear they know when their period is. And when you do an ultrasound, it doesn't correspond. So there's a certain window. So if the growth of the baby is within 1 week, then you actually can say it's based on the period. But once it's more than 7 days, you actually use the ultrasound date. You do not use the period date. Because some women ovulate late and some women ovulate early.
All right.
And that's how you date a pregnancy, based on the size of the baby.
Okay, ultrasound.
Ultrasound. And then also you're looking at the baby's heartbeat to make sure that it's normal.
Right.
Right.
And you're getting that at the 5-week visit?
Between 5 and 6, well, more like 6 weeks.
Okay.
So 6 weeks, you can see all of that.
All right.
Also, sometimes there are things called an empty sac. So while you will see the big black circle, which is the pregnancy sac, there's nothing else inside of it.
The big black circle, right.
Right.
Okay.
And that's called that's called an anembryonic pregnancy, and some people might know this as a blighted ovum. That's a different term, but we use the term anembryonic pregnancy. So you are pregnant, but there's no baby inside that sac.
Okay.
And then sometimes there is a pregnancy, you see the baby, but there's no heartbeat.
Yes.
And that's called, unfortunately, a missed miscarriage.
A missed miscarriage.
Miscarriage. So, so you can see all those things between 6 to 8 weeks.
Okay. I could see the importance of why you have to do it.
Yeah. And then, so the next visit will be at 12 weeks, as you were saying.
Right.
And at 12 weeks is important because there are high risks of miscarriages before 12 weeks.
Okay.
And the miscarriage rate on average is 20%. So while a lot of women feel very bad about a miscarriage, they don't realize that miscarriages are very common. So 1 in 5 women. So if you talk to 5 women, 1 will have a miscarriage for sure.
Okay.
Right? And it's also based on age. So the older you are, the higher your chance of a miscarriage.
And this is before the
up to 12 weeks. This is why most women will not tell you that they are pregnant until they're 12 weeks.
Right. Okay, so it makes sense now.
Yeah, because, you know, exactly. So 12 weeks, you do an ultrasound, you confirm the baby's good.
Right, so the risk of miscarriages decreases tremendously logically from what you're saying.
Exactly, after 12 weeks.
Okay.
And that 12-week mark is the time that we say, yes, time to do other investigations.
Right.
So this is where you would do your blood pressure, your urine, your weight.
Yes.
Right? So this is a urine test. And these are all baseline tests. Then you would then recommend what is called your booking blood investigations. So everyone has to do a blood count because you can be anemic. And you can also have things like sickle cell and thalassemias, which will be picked up in a blood count. Then you would want to know your blood group, because this is very important for later on in pregnancy, because a woman who is group negative has to get special injections in pregnancy.
Okay.
Because if your baby is group positive and you are group negative, you can form this thing called antibodies against your blood cells. And this can have detrimental effects on a baby. Okay. So you need to know your blood group.
Early o'clock.
Then the other blood tests would be for screening for infections. So HIV and syphilis, standard worldwide, because they're treatable in pregnancy. Abroad, hepatitis B and hepatitis C now is actually common. We don't actually screen for that regularly in Trinidad. You do your rubella immunity. So in Trinidad, everybody gets their MMR shot, right? We don't usually have an option. It's given to you as a baby. Yeah. But however, we haven't had rubella for many, many years. However, there is an upsurge because of migrants coming into the country. And a lot of people, and I'm not talking about any specific group of people.
People that's not vaccinated.
People are not vaccinated worldwide, and they have a choice. So we have seen rubella recently. So a lot of people come to me saying, well, here's my vaccine card. I'm sure I've been vaccinated. Right. But when you do the blood investigations, you actually see that they're not immune. Right. So they may have actually missed one, or they didn't form an immunity. Right. Now, you can't actually give the rubella vaccine in pregnancy, but you're preparing for the next pregnancy. So if you don't have it, at least you know when you deliver, you get your vaccination post-delivery. Okay. Right? Recently, we've started doing the glucose tolerance test at your book-in visit because we've picked up a lot of diabetes in Trinidad. So the recommendation now is to do what is called the GTT at your book-in visit, which is the 12 weeks. Okay. And it's repeated later on. So that's the basic thing.
So on the slide there, has if one metformin medication stop?
Right.
That's interesting.
Right. So remember I was telling you about the risk of miscarriages with polycystic ovarian syndrome?
Yes.
Right. So women who have polycystic ovarian syndrome, it has been shown that metformin, which is one of the treatments for polycystic syndrome, being on that decreases your risk of a miscarriage in the first trimester.
Right.
So you can stop your metformin at 12 weeks once you know the baby is okay.
Right. So it's not that you're stopping it, it's just that you can stop it.
Yes.
Right.
Yes.
It's not that the metformin is going to cause a problem.
No, and it's actually recommended in pregnancy.
Okay.
One other point that I forgot to mention is low-dose aspirin. So there's specific indications for low-dose aspirin, and women start it at the 12 weeks. And for recurrent miscarriages, preeclampsia, and women who've had stillbirths or late miscarriages in the past, preterm labor, not actually preterm labor, but what you call stillbirths before preterm stillbirths.
Josh, could we just get back this slide back up, please? What features would you see in the ultrasound of the baby at 12 weeks?
So at 12 weeks, a baby is fully formed. So as you can see the side profile there, you can actually see the head, the body, you can see the limbs. So in front of the head is a hand, and lower down would be the lower limbs.
Is that the spine?
And the spine in the back. So the white in the back is the spine.
Right.
So bone appears as bright white on an ultrasound.
Okay.
So, and this is why it's important for you to optimize any medical condition. I think we could recognize a
lot of features there. I think we see in the head, we see in the spine, we see in his hands. There's a leg. There's his
leg at the bottom,
everything. Very good.
And if you look at in the head, that white area is actually the brain developing.
Wow. And I see that you have the babies the size of a passion fruit.
Yeah.
Okay. All right, so a tiny little creature there. Very good. All right, so what else happens at the 12 weeks?
So some women may try to switch from the just pure folic acid. Because remember, in your first trimester, this is when you have the most nausea and vomiting. Prenatal vitamins, the only difference with them is they have extra folic acid in it. So one mistake that a lot of people do is they take a prenatal plus folic acid.
Right.
You don't need to, because the prenatal vitamin has extra folic acid. That's why it's a prenatal vitamin.
What else is in the prenatal vitamin? So, and we're going to break this now. We're halfway there.
Okay.
But what other vitamins is it as a component of the prenatal vitamin? What do you get
it's a multivitamin. It's a multivitamin with extra folic acid.
Yeah.
So all the vitamins vary, and there are few where you can actually get stool softeners as well, and what's extra in some of them is omega-3 or DHA.
Okay.
So those are the better ones to get.
Okay. Yeah. So I think now is a convenient time. We'll take a little break. So we're going to take a little break. Dr. Roshni Bissoondat is in with us tonight. It's a bit challenging topic for her to put forward in the space of 1 hour. She's taken us from conception to birth. So far, we have reached at the 12th week. 12 weeks. So we're halfway there. And we'll be back in one moment. And after the break, we will take your questions and your calls at the beginning of the second break. Thank you very much.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest. You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance. Explore the many ways to make your harvest right for you. Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture. Sponsored by Munich Home and Garden, the Agricultural Development Bank, and the Plant Doctors.
Our lives feel so different now. School is more intense, work deadlines are shorter, and traffic takes hours every day. Despite all this, I want my family to have wonderful meals and spend time together, just like I did growing up. In my house, it's only Caribbean flavors. I spend less time at the stove and more time with the people I love. Quick, easy, delicious. Caribbean flavors.
September 24th, right here on the evening show, we'll be having 12 days of giveaways. And the rules are pretty simple, Kimberly. All you have to do is watch the evening show every day at 6 p.m. Yep, for a chance to win big this Christmas.
Hi, welcome back, guys. My name is Dr. Roopnarine. I'm with Dr. Roshni Bissoondat. And right now, we are at the 16th week of pregnancy. So, Roshni, if you could continue on taking us from the important aspects of a medical visit at 16 weeks of pregnancy.
Right, so 16 weeks, you're just checking the growth of the baby because sometimes you may pick up a slight chromosomal abnormality because a baby is smaller than it's supposed to be.
Right.
So again, that's just growth, and you're just doing your normal routine, your blood pressure, weight, and urine, which at every single visit, right? One thing
I think we have it up on the screen there.
Right. This is very important because a lot of couples want to know the sex of the baby at that visit. And once a baby is in a good position, you can actually see the sex of the baby at that point.
Can we see the sex of that baby that you have?
No, because that's a side profile. The baby needs to be turned towards us to see the sex of that baby.
Okay,
so again, you can see the baby's a lot bigger. You could see definition within the head and the brain. You can actually see the brain very clearly developing there.
Right. Is it at 16 weeks you have the anomaly scan?
No, that's the next step.
Okay. All right. So
which is at 20 weeks. So that's your next visit.
We can move on to that.
Yes. So at 20 weeks, there's an important ultrasound that's done, and this is called the anomaly ultrasound. Okay. So this looks at all the internal organs of the baby, looking at the brain, the facial features. You're looking for cleft lip, cleft palate. You're looking for a nasal bone. Then you go to you're looking for thyroid swellings. Then you also look at the chest for the lungs. You look for the diaphragm, because sometimes you can have a hernia in the diaphragm where the baby's bowels end up in the chest. You're looking, importantly, at the heart, the stomach, liver, kidneys, everything like that you can see.
Right.
One thing to note in the anomaly ultrasound, it's about 92 to 96% effective in picking up abnormalities, except for the heart. The heart is only 55% accurate. And people need to understand this, because it could literally, an abnormality could only be detected after a baby's born. And the first thing they say is, well, I did an anomaly ultrasound. Why didn't you pick it up?
Right.
Just to know that it's not 100% accurate. But we try to pick up most major abnormalities.
Is it dependent on the ultrasound that the person uses as well, that the practitioner uses? For example, I've seen people saying like 4D ultrasound, different types of ultrasound machines.
No, it's more. It can be with the ultrasound, but it's also the person that's doing the ultrasound.
Right.
So how often they do it, were they qualified, or have they trained in doing anomaly ultrasound? So that's the most important thing. 3D was really invented to pick up other abnormalities. When you see something, you then go into 3D to look at it in more detail.
Like what?
And cleft lip, cleft palate.
Okay, especially cleft lip and cleft palate.
Yeah.
Okay. And you were mentioning before there that maybe we should have put this in terms of the preconception, but is eating habits very important for patients when they're pregnant?
Well, right. So yes, you're correct.
I'm going to put you on pause, and I'm going to ask one or two questions, which I think my patients would have wanted to ask you. So go ahead. So is eating habits very important of the patient?
Right. So we do advise on healthy eating. So you're having all your food groups.
Yeah.
So your carbohydrates, your proteins, your fats, your fruits, your vegetables, because that's where you get your minerals.
Yeah.
But there are certain foods that we do try to avoid in pregnancy, which would be raw, undercooked fish, meat, or eggs, because you can get salmonella poisoning. Soft cheese, you can get a bacteria called Listeria, and that could cause miscarriages as well. Certain fruits you should avoid, such as green pawpaw.
Okay.
But ripe pawpaw is perfectly fine.
Okay.
Because there's an enzyme that can cause miscarriages.
Right.
You have to minimize pineapples.
I apologize. Your eating habits are extremely important in the first 12 weeks of pregnancy.
It is.
Because the major risk within the first 12 weeks of pregnancy is miscarriage.
It is.
And
exactly.
there are certain foods that you tell me that could cause miscarriages. Okay. Actually, that reinforces to me something that I always thought that the eating habits are extremely important.
Yeah.
So, other than the eating habits of our patients, right? I know we're going through sequentially, but I'm going to stop you a little bit, and I need to ask this question. During this first 12 to 20 weeks, patients get very nauseous. The ladies suffer from morning sickness.
Right.
What advice do you give to your patients in those visits to treat the morning sickness? Or
so you can use natural
What
things.
is morning sickness?
So, we call it morning sickness, but you can say all-day sickness as well.
Sickness.
Yeah, because, well, first of all, morning sickness because your hormonal levels are highest in the morning where you get the nausea.
Okay.
But some women, unfortunately, have it throughout the day.
Right.
So, it's just very common. And natural things that you can use for it would be ginger. Ginger has been shown to be extremely good for nausea and vomiting.
Okay.
So, ginger drinks, ginger mints, ginger tea, anything except ginger beer, of course, no alcohol. And then you can actually get nausea bands or vomiting bands. They do work because that works by acupressure.
Okay.
Yeah, so that works as well.
Right.
And then you have safe medications for pregnancy.
Right.
So again, you can use oral medications, and if you're vomiting all the time, then you may have to unfortunately use either the injection type of medication or per-rectal medications that are available.
The common ones would be in gravel.
While gravel is very common in Trinidad, it's not the first-line treatment for nausea and vomiting.
Okay.
It's more like Stemetil is very good, Maxilon and Motilium.
Okay.
Yeah, those are better for pregnancy.
Okay.
Yeah.
And all right, so those are the 3 basic tablets that you could use for morning sickness,
right?
Which is an extremely common complaint in general practice. People, just today someone called me up and asked me about how they have really bad morning sickness, they want some help.
Right.
I told them to wait till tonight when you come on the program and I'll find out. But, so the morning sickness. Sorry to interrupt, and you could continue on from the 24th week.
Right, so at 24 weeks, again, we just check in growth of the baby, but at that visit, it's important because we want to look at the fluid around the baby, make sure baby is still growing well, and what is also very important is we repeat the glucose tolerance test.
Right.
Because while you may not pick it up in the first trimester, gestational diabetes can come out much later on. So we screen again at 24 weeks and we repeat your blood count because your blood count could drop based on the baby taking a lot of iron from you.
Right, obviously.
Right.
All right, so we can move forward again. Josh? Pop the next one. So after 28 weeks, what do we do there?
Right, so 28 weeks is when we now say that a baby is truly viable.
Yeah.
And when we talk about that, we talk about the reason we say 28 weeks, it means survival. So if a baby comes before 28 weeks, your chances of survival are not as great as when you reach to 28 weeks. So this is why we place so much importance from 28 weeks onwards.
Right.
Now, some babies will survive under 28 weeks, but it's not the majority.
Okay.
Right, and from 28 weeks, this is your third trimester, and this is when things start to sometimes get a bit sticky, or a lot of complications can start to develop from this point.
Okay.
So from 28 weeks onwards, we pay special attention to the growth of the baby because you can have babies with what you call IUGR or intrauterine growth restriction, and this is where the baby is smaller than it's supposed to be. Other signs other than the size would be less fluid around the baby. Other conditions that can occur at 28 weeks would be cholestasis in pregnancy, and this is to do with your liver. You can also have too much fluid around a baby. This is called polyhydramnios.
and checking for urine and glucose.
Right. So protein helps to determine to key you into preeclampsia. Glucose for gestational diabetes.
What would excessive accumulation of fluid, amniotic fluid around the baby? What's the risk? What's the risk that? What's the risk there?
So if you have a lot of fluid around the baby, depending on the amount, if it's extremely excessive, and we use, so normal in our terms would be 10 to 20. So 30 and above could predispose someone to going into preterm labor because their tummy is just enlarged. So it's a trigger to go into labor, but you mightn't actually be more than 34 weeks. So you can go into preterm labor. What also is important is if you have too much fluid, a baby's head may not be sitting on the cervix. So what could happen is when the water bag bursts, the cord could come down in front of the baby's head. And that is one of the true emergencies in obstetrics. Because you literally have 15 minutes to get a baby out to prevent oxygen deprivation to the brain. So that's one of the risks of polyhydramnios. And then because there's so much fluid, a baby may not be head down. The baby can actually keep turning. So that's called unstable lie and even unstable presentation. So baby remains in either like a transverse position or bottom down.
Is there anything different in terms of the features of the fetus that you would see, or the baby that you would see from the last scan to this scan?
Not always. Not always. They get bigger, but there's just too much fluid around them.
The most important things that you're looking for in the scan is really the lie of the baby.
And
the placenta.
And the placenta, to make sure that the placenta isn't low lying. But that can be picked up at the 20-week ultrasound.
As well? All right. Any medications are given to the mom at this time?
Not unless you pick up a problem. So if you pick up what you call the IUGR, and you're thinking this baby needs to be delivered, we don't call it retardation, restriction. So if you're planning on early delivery, a small baby. So you could have two types of small babies. You can have a small baby, which means it's a constitutionally small baby because you might have a small mother, so nothing is wrong. Or you can have a baby that is small because there's a problem with the placenta. And those are the babies that you might be thinking of delivering early. So from 28 weeks onwards, you may have to consider giving a baby steroids. So the steroid we give is dexamethasone. Other countries give betamethasone. And what this does, it strengthens the baby's lungs. It releases a substance called surfactant, which when the baby takes a first breath, the lungs are able to stay open. If they don't produce surfactant, every time they take a breath, the lungs collapse again. So it's important to give that injection if a baby is going to be delivered early. Also, in terms of the intrauterine growth restriction, the way you can monitor a baby is a special ultrasound called a Doppler. So you're looking at the blood flow within the umbilical cord. Because babies especially in conditions called preeclampsia, you have a backup of blood flow because of the pressures within the cord. So instead of the blood going forward, it stops or it goes backwards, and that's a very bad sign.
All right. So the next visit will be?
So routinely, after 28 weeks in a first-time pregnancy, it should be every 2 weeks until 36 weeks. In a second pregnancy, after 28, you go to 32. And then from 32, it's every 2 weeks until 36, and it's weekly thereafter, because this is a critical time. Again, if any complications develop, there's no hesitation to deliver a baby.
So we have another slide up there.
So this is when you reach full term. So we call full term at 37 weeks. So between 37 to 38 weeks, and I tend to more go to 38. I don't really do it at 37. You can offer what is called a cervical check. And this is just to check to see if you think a baby might come soon or not. Some women would accept what is called a cervical sweep, which is inserting your finger and what you call sweeping the membranes. And this releases what is called natural prostaglandins. Natural prostaglandins could bring on labor. So this is mainly done in women who've had babies before, and it works better in someone who's had a baby. That prostaglandins could literally bring on your labor anything from a few hours after to a few days after. But it's not harmful. So if the baby doesn't go into labor, it's no harm.
Okay.
Right?
I see you have the predict chances of a general delivery versus cesarean section.
So you can sometimes predict if somebody might have a normal delivery based on that vaginal examination, because some women have what is called a very narrow pubic arch. So there's very little space there, and a baby's head could come down and get stuck. And you just wouldn't dilate.
Right.
So although we try to predict this, the studies haven't shown that it's very accurate. And sometimes people do these things called clinical pelvimetry, where you use your hands to measure the pelvis and stuff. But
can I just ask you now to just take us, well, I think we went through the majority of the prenatal care. Can you just now take us on to game time when, so our patients are in labor and they're getting contractions. What happens next there?
Right, so the most common signs of labor would be contractions. So contractions will start further apart.
Right.
And three things that you're looking for: it's getting closer, lasting longer, and getting stronger. Those are true signs of labor, because you can have false labor or the Braxton Hicks contractions.
Correct.
So one way is to time it and know, well, this is getting closer.
Is Braxton Hicks contractions only at the final stages of pregnancy?
No, you can get that from 20 weeks onwards.
Right.
So women do experience it, and they sometimes say it was just a period cramp.
Okay.
But to really know closer to the time if it's a true labor pain or it's a Braxton Hicks, it's the timing. And it, as I said, gets closer, lasts longer from like just a few seconds, 10 seconds, it will build up to a minute.
Right.
And it will get stronger. So where it's very mild, where you can walk around and, you have no problems, it stops you, where you have to like hold something. So your pain is bad. So that's true labor.
Okay.
The other two signs would be if your water bag bursts, but it's not always a good sign, because your water bag can burst before labor. So it bursts and then nothing is happening. But you do see somebody, you go into either the hospital or see a doctor if that happens.
Right.
And then there's something called the show, which is mucus with blood. But that could happen from 2 weeks before you have a baby. On average, it's a few days before to the same day, but you just know that it's coming on. But it must have blood in the mucus. It's not pure mucus alone.
Right.
So those are the signs of labor. And when you're in labor, you're now checking to make sure that you're what you call progressing well.
Right. So the patient, she's in labor now, and she calls you up, Dr. Bissoondat, and you'll be my obstetrician from the start, and I'm coming to see you. What happens next? So they take them into theater, into delivery room?
We have a delivery room.
So what happens?
So you come in and you're checked, your cervix is checked. It's important
for the pregnant women at home to hear.
Right.
So what's going to happen?
So wherever you're going, so it doesn't have to be with me, but anywhere or even in the hospital, you have to have what you call a cervical check. So that's on the labor ward, and you check for your dilation. So a woman will start from 0 and have to go to 10 centimeters. So that's how you check. And somebody in their first pregnancy, the average rate is 1 centimeter per hour, and someone in a second pregnancy, it's much faster. So that's what you're checking for. Right? So you're checking the dilation, you're checking to see if the water bag has burst. Right? Obviously, you're checking baby's heartbeat. And if things are not progressing well, then we do things to help it along.
Right.
So if the water bag didn't burst, you burst the water bag.
Right.
If you're not dilating the way you should, then we start the drip, which is called oxytocin.
Right.
And that speeds up your labor.
Right.
Right? So, and then at the end, you're looking for a normal delivery, which is when the head comes down and the woman starts pushing. So again, in a first pregnancy, you're allowed up to 1 hour of pushing. In a second pregnancy or more, it is less. So generally, it's half an hour is what is allowed.
Right.
And it's not only that, it will just happen naturally, because a baby sometimes isn't facing in the right direction. So it's head down, but a baby could be looking up to the mommy's tummy instead of looking down towards the bum.
Right.
And the effect of that is that it could be a longer labor and a more painful labor, because the head diameter is 1 to 2 centimeters more when a baby's looking up or looking to the side.
Right.
So we check for this to see if the baby head rotates in labor. So the best position is when the baby's head face is facing the mommy's bum. And that's the easiest labor.
All right, so now will be a convenient time for us to take a little break before the baby arrives, and we'll be back in 1 moment. Thanks. Yeah, so...
to the Chuttock's Kitchen, where it's tastier and spicier. For even more taste, cook with Chuttock's Amchar Masala, saffron, ground jeera, and black pepper. Mix in Chuttock's mild, spicy or Madras curry. Get a burst of excitement with a mango amchar, pomsade and mango kuchila, lime and pepper chunks, West Indian hot sauce, and lime pepper sauce. Plus, Chuttock's tamarind and mango chutneys are perfect with palori and sahina. So make your kitchen a Chuttock kitchen. Chuttock's fruit products, bringing good taste to life.
At Extra Foods, we care for you. That's why we always have the widest variety, the best prices, spacious aisles of total convenience, plus clean, safe surroundings. Let us care for you. Extra Foods, always extra for less.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen. Stacy will be packing up her trolley at Prasad's The Food King supermarket and making a special stop at the Chaddock Lane. We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients. Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice. Munich Home and Garden specializes in hardware, paint, home decor, tools, agricultural supplies, pet supplies, car accessories, appliances, and much more. Located at Val Park Shopping Plaza, Atlantic Plaza, Point Lisas, and Eastern Main Road, St. Joseph. Shopping comfort with our well-secured outlets. Call us at 663-5163 or visit the Munich Home and Garden Facebook page or www.municht.com. Munich Home and Garden, where we make shopping a fun experience.
All right, so welcome back, guys. We're back here with Dr. Roshni Bissoondat, and we just would like to say that the phone lines are open now. And you can send in your calls and you can send in your messages and we'll get to it. So, Roshni, at this point in time, we are at the stage of the different modes of delivery. Can you take us through that?
Right. So, the two modes of delivery, one would be a vaginal delivery and the other would be a cesarean section. Mm-hmm. So, most women would try for a vaginal delivery, and the success of a vaginal delivery is about 80%. Right? So there are two reasons you would know that you're definitely having a cesarean section would be if the baby is breech or bottom down or not head down. So anything but head down, you do elective cesarean section.
Right.
And the second reason is a placenta previa, which is when the placenta is low and sometimes covering your cervix. So the baby can't come through. So those are the two reasons you know up front. Now, there's one other special reason, and that is maternal request. So women have, nowadays sometimes come and say, well, I don't want to try for a normal delivery.
Okay.
While we do try to convince them you need to find out the reason why they don't want to have a normal delivery. Sometimes it's psychological, it might be physical, sometimes they might have been abused in the past or something like that. So we do take into consideration the lady's request.
Okay.
So then, in addition to normal and vaginal, you might then talk about a vaginal birth after cesarean section. We call that VBAC. And it is possible.
Right.
So, a lot of women come to me saying they had a cesarean and they were told they have to have a cesarean. So I just let you know, let other women know that that's not entirely correct. It might be a misinterpretation because it depends on the reason you had the cesarean section.
Okay.
Because if it's not a recurrent reason, you can try for a normal delivery.
Each pregnancy is different.
Each pregnancy is different.
Okay.
Right?
When I was over in Ireland and in the States, in Trinidad we hear about everyone goes to the hospital and has a baby. It's either vaginal or a C-section. But when I was abroad, a lot of women were having babies at home. something that was happening in the past. And that was a big movement as well, actually. There was a huge movement in Ireland at the time for people to have their babies at home with a midwife. Or sometimes women were having their babies in sort of a water
bath. Yes.
What's your thoughts on that? Why is it not? Is it something that is happening in Trinidad? I don't know. Is it something that recommended? Do doctors have problems with it, or just give me your opinion on it, because I think it's something very important for people to know what happens in other parts of the world and the different modes of delivery. Okay,
so we do have home births in Trinidad, and that's conducted by midwives.
It used to be like that in the generation past.
Correct.
And then it kind of slowed down with everyone going to...
And that's mainly because of different complications.
Right.
You know, your diabetes, your hypertension. Right. But if you're a low-risk patient, then a midwife accepts you, and yes, she will do a delivery at home. So it is still being done in Trinidad.
Good.
Water births, I think there's one center in Trinidad that does it.
Right.
So nothing is wrong with doing it once you are a low-risk patient.
Why would a woman choose to have a water birth? Is there any benefit to it?
They're saying that the environment is very similar to being inside the womb. So remember, baby in the womb is in the fluid. So if a baby comes out in the fluid, it then swims up to the top, and so that the oxygenation, and it's more natural. So a baby tends to do better. So that's their theory as well.
Okay. So. All right, so just to bring it back, so we've had a natural vaginal delivery or C-section and the baby's out. What happens next? Call for the pediatrician, or how does it go?
Right, so yes, a pediatrician then sees the baby after the delivery, and mother is taken care of during that time.
Right. And is there a follow-up visit to yourself afterwards?
Right. So generally there is, if you had a cut or a tear, you would follow that person up 1 to 2 weeks after delivery. I generally do it at 1 week to make sure that the cut is healing well. Your true postnatal check is at 6 weeks after delivery, because this is what we call the end of the purpurium, where everything goes back to normal. And at that visit, it's a good opportunity to do pap smears, so which is a test for cervical cancer. We discuss exercises, because there are 3 exercises that generally should be recommended. Is your tummy exercises, your Kegels normal keep fit, and your Kegels exercises. Which is
that brings me to an important question. Sorry to interrupt again. Should women be exercising during pregnancy? In the past, I think older GPs and older doctors would tell people, well, you can't be running around doing exercises, aerobics. I think nowadays, though, again, from my exposure abroad, I see women quite late in their pregnancy doing.
It is recommended to keep fit in pregnancy. So exercising, you can exercise in pregnancy. It's just no high-impact aerobics and no heavy lifting, weight lifting.
Of course.
So, yes, you can exercise. You can do your cross trainers, your bicycle.
It's important.
Treadmills, but you have to be cautious on a treadmill, especially with the incline, because your center of gravity changes and you can fall off. So that's the main reason for not going on treadmills.
All right. So I just want to take you back to that final 6-week check. So you've given the patient advice on exercises, and that's basically it.
No contraception.
Contraception.
We always discuss contraception, because again, your baby is only 6 weeks, and literally once you see a period after delivery, it means a new egg has come out, which means you can get pregnant for every month after. So we do speak about contraceptive.
Okay, so I think, Josh, do we have any phone calls or messages coming in? We had a few messages left over from last week's show. All right, can you put the call through, please? Hello?
Hello, yes.
Hello.
Hi, I have a question for Dr. Bissoondat.
Yeah, go ahead.
If someone is diagnosed with gestational diabetes, right, and they're usually a good, healthy eater, but they went through a kind of, I don't know how to explain it, a kind of series of emotions where, like, I'm pregnant, I can eat what I want. So you start to eat stuff like soft drinks and buying snow cone. Yes, you get on bad. Buying snow cone, eating all kind of chipiness, buying goat roti, you name it. whenever you feel for a roti, you're not cooking at home, because you don't want to stand up and hurt your feet. You're buying it out, eating all the oily food.
Right.
And the night, at 25 weeks, the night before your GTT test, you decide you're going to eat plenty because you're fasting the next day. So you buy barbecue lamb with macaroni salad and fries and eat a whole set of food.
Right.
And then when the results come out, the fasting level is incorrect.
Yeah. Okay.
Yes. Can that episode lead to you being diagnosed gestational diabetes or?
Okay.
Please.
No problem. I think we got to just say a question, and Dr. Bissoondat will answer it. And thanks very much for calling.
That's a very good question, because actually I've been picking up a lot of gestational diabetes over the last 2 years, which I think is due to the lack of activity due to COVID and everyone being at home. So there's a specific diagnosis of gestational diabetes, and that's if your fasting is, and the guidelines have changed, which a lot of people don't know. So if your fasting is less than 92 or less, that's normal. So anything above 92 for fasting is gestational diabetes.
Okay.
And if your 2 hour is more than 153, so it's a tight control or tight change in pregnancy now.
Right.
So yes, what you eat affects whether, not affects whether, but basically if you eat a lot before your glucose tolerance test, yes, you can get a high reading. But remember, your body is supposed to compensate for heavy intake. A normal, if somebody is not gestational diabetic, you're supposed to produce insulin in a way where it breaks down that glucose.
Right.
So you should still technically get a normal reading. However, as you said, if you really had a very heavy meal that you're not accustomed to, then yes, you can get a high reading, but it would still say that you're gestational diabetic.
Okay.
You just have to check your diet scans after.
Giles, do we have any WhatsApps? Okay. As Roshni, these WhatsApps came in last week.
Okay.
But we need to attend to the questions. Can antidepressant tablets, example, fluoxetine, cause prolonged hot flashes? As
far as I know, it doesn't cause hot flashes. But some evidence is showing that sometimes it might or it might not help to treat hot flashes.
All right. So the jury's out.
Yes.
All right. Giles, do you have any? Nice topic. Can you get pregnant going through menopause?
No, because menopause means you have no eggs remaining.
Great.
So, no.
All right. Giles, do we have any further? Right. I'm at 55 and I was tested once and the test was negative, but the bleeding occurred again recently. What else besides cancer can cause the bleeding? I suppose this patient is having uterine bleeding.
Uterine bleeding.
And post, I am assuming, based on the information there, postmenopausal bleeding.
Correct.
And the gynecologist tested the person for cancer. So what else? And that's negative. So what else could cause this bleeding?
Right. So most common is something called atrophic endometritis.
Okay.
That just means it's menopause causing it, because your womb is shrinking down, and which means the lining of your womb is also shrinking. So when it's shrinking, it causes a little release of blood.
Right.
So that's one. And the second one is endometrial polyps, which is a little growth inside. That could also cause postmenopausal bleeding.
All right. So can we take another message as well? If you have Alzheimer's, does it affect menopause?
No. Alzheimer's is a condition by itself.
All right. Giles, hi, good night. Is it possible to remain with diabetes after being diagnosed with gestational diabetes during pregnancy?
Yes. The answer to that is yes. And we always check at 6 weeks after delivery to make sure that you are not diabetic after delivery. So it is common. And for women to know, diabetes, majority, 80%, is brought on by diet, lack of a healthy diet, and lack of exercise.
Okay, very good. Well, Roshni, we have about 2 more minutes left in the program. Again, it flew by.
Yeah.
And, well, first of all, I think I want to congratulate you for basically giving the viewers at home an overview of 9 months of obstetric care, which is the basis of the entire obstetric course in medicine in 1 hour. And I think our viewers at home would appreciate it a lot. So before we wrap up, I just want to give you the final word to all the viewers out there, especially the women. You being an expert in women's health, I'll let you leave the viewers with a message on women's health. What would you like to say to our viewers out there?
So it's important for you to know about your health and the health of your baby. And I would say having a baby is not about the delivery alone. It's about the journey from conception to delivery and delivery of a healthy baby. So though leading up to the delivery, I would say is 70% more important than the delivery itself. So take care during the pregnancy for you to have a healthy baby. Okay.
All right, that's very good advice. All right, guys, so that's it for today's show. We'll be back next week. Next week we'll be going back to the COVID pandemic. We'll be finishing off the final 2 or 3 shows for the season on the COVID pandemic. I would just like to thank Dr. Bissoondat for coming in here tonight and helping us out with this Women's Health mini-series. And I would like to thank you at home, and thank you very much for tuning in. Thank you to all our callers, and thank you for those sending in messages. So please have a pleasant evening, everyone, and we'll see you again next week. God bless.